TERAVOLT, which was presented at ASCO, is a global consortium that was actually started from an email from Dr. Marina Garasino from Milan, who was worried about how COVID would impact our lung cancer patients, and also what would be the impact not only of the illness, but also on the pandemic in terms of the outcomes, in terms of delays in care. So she sent an email out to about 50 investigators around the world. I emailed her back straight away and said, we'd love to help you, and we can set up this database here at Vanderbilt. And within 1 week, we had a case report form set up and had IRB approval, both locally at Vanderbilt and nationally in Italy, for investigators around the world to enter their data on their lung cancer or thoracic cancer patients with COVID-19. And it's not restricted to lung cancer. It also includes mesothelioma and thymoma and carcinoid patients, and both small cell and non-small cell patients. The criteria for enrollment in COVID is that the institutions have to have local IRB approval. A patient has to have a COVID diagnosis either through RT-PCR, a suspected case with a known contact with someone who's COVID positive, or based on radiographic images and symptoms suggesting COVID. The median follow-up of patients that were included in the data cutoff for ASCO was 33 days. And we presented data on the first 400 patients who had complete information entered in the case report forms. It included patients from both the US, Europe, South America, Canada, as well as parts of Australia and Asia. We found that the median age of patients was around 70 years of age. The majority of patients were male and were either current or former smokers. In terms of underlying comorbidities, we found that in the patients were sort of classified into 3 groups: those who had recovered from their COVID diagnosis, those patients who had died, and those patients with ongoing infections. We found that in the patients who had recovered from their COVID diagnosis, that more of those patients were likely to have no comorbidity, around 18%, compared to those patients who died. Only around 9% of patients had no comorbidities, with the majority of patients having 1 or more comorbidities. The most common comorbidities, and we've heard a lot in non-cancer populations about hypertension and diabetes, as well as vascular disease being risk factors for mortality from COVID. We found that these were common risk factors in our cancer patients, but didn't find that any of these specific comorbidities were associated with increased mortality from COVID. We also looked at therapies in the last 3 months, and we were surprised to find that the majority of patients either had no therapy, so around 25% of patients, or had only had 1 line of therapy at the time of their COVID diagnosis. Common complications from COVID were pneumonia or pneumonitis, ARDS, sepsis, coagulopathy. When we looked at risk factors associated with mortality from COVID, we used something called the Gray's test, which looks at the cumulative incidence of a specific death, basically, from COVID, and we compared kind of death to recovery. And we found that in patients, the risk factors for death were age over 65 years old, presence of a comorbidity, but we could not figure out which one specifically, as well as an ECOG performance status of 1 or 2. We also found that patients who were on steroids of greater than 10 milligrams of prednisone equivalent or more, who were on anticoagulation, which could have included heparin, any of the DOACs, such as rivaroxaban, or patients who were on warfarin, were at increased risk of mortality. And we also found that patients who received chemotherapy, either alone or in combination with immunotherapy, were at higher risk for mortality. Surprisingly, we found 35% mortality in our patient population, with about 80% of patients' deaths being attributed to COVID. 78% of patients required a hospitalization, but only 8% of patients were actually admitted to the intensive care. When we looked at the therapies that patients were given, there's been a lot in the media about, different agents, and CCC19 presented at ASCO and found combination use of hydroxychloroquine and azithromycin were associated with increased risk of mortality in cancer patients. We didn't find such affiliations between the therapies that were administered to our patients. In the multivariate analysis, it was age, ECOG performance status of 1, prior steroid use, and chemotherapy that again held up as being increased risk of mortality from COVID-19. So this database is ongoing. At ASCO, we had 400 patients presented. We're now up to over 550 patients entered in the database. We're continuing to look at risk factors for mortality. We're also looking at therapies that could potentially improve patients' outcomes later on down the line. We're also looking at, importantly, how does having a COVID pandemic affect lung cancer treatment in general? And so what are the delays in patients' cancer care? And then we will soon have a patient-related survey launching on our website, which is TERAVOLT-consortium.org, looking at patient factors, or what the patients are thinking in terms of how COVID is impacting their daily lives and how it's impacting their care. So I don't think that we should stop offering care. We're doing a few things at our institution. So first of all, anyone who starts chemotherapy, we're testing them for COVID. And if they come up as positive for, well, we're testing them for SARS-CoV-2. If they come up as positive, we're potentially delaying their therapy until they clear. And so I don't think that we should be stopping therapy. I think we should be just very careful about how we're giving therapy to our patients. So advising our patients, to kind of take those neutropenic precautions even further, telling people to stay away from crowds, to stay away from other people. This is a serious virus that is going to continue to spread and be with us for some time. But I don't think that we should be stopping care in our patients, but it may require at some point a delay in initiation of care if a patient tests positive prior to starting on therapy. The study, we're going to continue to collect data. I think that there are two things that we're looking at. One is a lot of the patients who were in this initial analysis were patients who were hospitalized and who were sick. And I'm hoping that we find more asymptomatic cases with time, and maybe we find that there's a better outcome for our thoracic cancer patients. The mortality in the CCC19 was less than 20% in an all-comer patient population. But for as long as the pandemic is ongoing, we'll continue to collect data. I was on the conference call with the other steering committee members, Heather Wakely and Solange Peters, and we were talking about, looking at different outcomes in the study. And, we said something about a live meeting. And as Dr. Peters said, Solange said, a live meeting will mean that we have a vaccine, and so the pandemic is over. And at that point, we'll close the database. What we'd like to do is also kind of figure out what's the risk, what is the prototype of that risk patient look like, so that we can potentially help as the pandemic continues and everybody's worried about that second wave, and say, if you have lung cancer patients with these specific risk factors of this specific age, you need to be even more cautious. Again, don't stop therapy, because lung cancer is a pandemic and it's not going to go away either, but rather be really cautious in how you're giving therapy and monitoring these patients and minimizing their interaction with both society during their therapy as well as the healthcare field.